Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic is a glaucoma lecture that's called Cornea and Nerve, two novel mnemonics to preserve vision in two parallel diseases. With our speaker tonight, a good friend and colleague, and we really appreciate, Austin, that you did this, Dr. Austin Lifferth. He is a graduate of Indiana University School of Optometry, and he also did residency in ocular disease at the Huntington, West Virginia Veterans Administration Medical Center. He has practiced in an ophthalmology co-management center for several years in Indiana and a hospital-based setting in the Villages, Florida, and is now back home in Indiana as a consultative optometrist with an emphasis in glaucoma and glaucoma management and at the Center for Sight in Carmel, Indiana. He's a fellow of the American Academy of Optometry, a glaucoma diplomate of the American Academy of Optometry, past chair of the glaucoma section at the AAO, and a member of the Optometric Glaucoma Society. Now, to clarify for people in the audiences, I also practice for Center for Sight, as does Austin, but they are two different practices that are unrelated. Only they are coincidentally having the same name. Austin, I have been told there's a Center for Sight in every state. I don't know if that's true. I'm sure they're not all of our practice or your practice, but Austin, very, very happy to have you here. Thank you for doing this. I know you're going to do a great job. You're one of the top thought leaders in glaucoma. So with that, please take it away.
Thanks, Joe. Appreciate the introduction. And yeah, I keep looking for you at work, but I just haven't seen you yet. So maybe one of these days. But thank you, Joe, for the introduction. And thanks, Greg, for the housekeeping. Congratulations to the two of you and OEC for 8+ years of amazing live and synchronous C courses. This is great. This is a fun way for us to learn, and we become better as a profession from things like this. So thanks for leading out on that and give us a quality education like that. With that, it's an honor to be a part of it. So I really appreciate this opportunity to take some time tonight and on your Tuesday night. To each of you listening, thank you for joining in. It's hard sometimes after a long day of clinic to join in and keep our brains moving, but I appreciate joining in. Hopefully it'll be helpful. Things I share, things that I've been learning that have helped me, that hopefully help you and your patients as well. So as Joe talked about, these are two novel mnemonics that hopefully can help us in our patient care. With every disease, I think in my interest is there's different facets of different diseases I find interesting. One of them is earlier diagnosis. It's just fascinating to me to try to see if I can find the right signs based on the right symptoms with the clinic testing to see if I can pick it up earlier. And that's just part of it, then deciding which treatment to do, proper follow-up. But I think earlier diagnosis is fascinating to me. So this kind of is an umbrella theme for all diseases, but also two specific ones that we'll talk about. I have no financial disclosures that are relevant to this discussion. All relationships have been mitigated. And personal disclosure, rather than a financial disclosure, Joe and Greg, I wish I would have better recognized this and appreciate this connection, this potentially inevitable and seemingly inseparable connection earlier in my career of these two parallel diseases. It's taken me 20-some years to appreciate this, and I feel like I'm finally getting to the point where I'm recognizing it better. Maybe to introduce this lecture, I thought I'd show a recent case presentation that I had that describes well what I'm trying to present tonight and things that I'm learning. In brief, 67-year-old glaucoma female came in for glaucoma testing, and important part of the history, she denies any pain or discomfort. But this is important. So remember that she's asymptomatic. No family ocular history. She is on a PGA every night at bedtime and artificial tear lubricants during the daytime and even gel ointments at nighttime as needed. Vision looks great, 20/20. And her pressures are 13 and 12, stable. A little bit hazy. Sorry for the hazy view there, but you can appreciate some superior thinning in the right eye and near complete inferior thinning in the left eye on the nerve scan, on the optic nerve photos. And correlates with OCT. I think it's important, whatever test we do, we put in the context of the optic nerve clinical evaluation. And by comparison, I wanted to show you that this is what we like to see. This is great to see that overall the trend is flat, it's stable. Structurally, looks like this patient with a current treatment Pressure seemed to be low enough, hasn't changed. Functionally, also we have stable results. So I want to show you over the last few years, these tests. And importantly, we have some correlating defects, but it's overall about the same or better than before. It doesn't show any progression. One thing I did want to show you is a little pro tip. I try to cluster my visual fields earlier within a few months just to get a baseline. And then you can extend it out based on the appearance and the test results. So I complete the exam and I take a closer look at the cornea, and doesn't look like much, something like we normally see as we examine our patients. Many times for your patients, they may have already been dilated, all the testing done, and by the time you see them, the fluorescence is gone. But you might see a little bit of what appears to be some staining on the surface. But as I stained it, I found there was moderate staining, maybe grade 2 or 2+. Not the best picture again, but focal, diffuse SPK. So I started to think, here's a patient with seemingly stable structural and functional tests, and then with better awareness, some moderate surface staining. So I have a question for you. This is where we can do the poll everywhere. If you're unable to scan the QR code, you can put this into your browser, just open a different screen on your phone, pollev.com /Austin Lifferth 070. So that's the question, is this patient well controlled? We know this patient's controlled. Looks like structurally and functionally, doesn't look like there's any progression. Pressures are good. She takes her eye drops at nighttime. But are they well controlled? And is there a difference for that? It's always concerning when I see Greg and Joe here, because I'm wondering what else they would do differently. But in my mind, it looks like this patient was controlled. And we'll see if this comes up. Does that click in for you if you have the polls?
Well, they are answering our polls, which
Oh,
is
good.
the
Okay,
same
that's
question.
perfect. Okay.
And interesting, use a phrase well controlled. I've always said well controlled is a phrase that can only be used in retrospect.
Okay.
Many times you'll have a patient with a pressure of 30. You start him on medicines or some other therapy, and the pressure drops to 15. And that is, 50% drop. And we say, well, the patient's well controlled. I like to say there's great efficacy of the medication. Now, in 5 years, when they look like this, when there's been no change, then we can retrospectively say, yeah, the patient was well controlled.
Yeah, that's a great point, that the medicine is working. And so for all the numbers, if we look at numerically, quantity-wise, they made all the numbers, they're stable like that. And then to look in hindsight to see how they're well controlled. And that's what I'd like to raise this to, a different level that's not just about the numbers, but are we doing everything we can to make this condition of glaucoma well controlled? I mean, it's good for the patient and it's good for the ocular surface. So moving forward, Greg.
Yeah, so you can go with your poll, and I can tell you what happened on our end is we have 69% people saying yes, and we have 31% saying no.
Okay. This is where it'd be great to have some discussion on those who felt like it's not well controlled. What else do we do? But I agree what I'm saying, that this patient, because of the ocular surface disease, I think I, as a provider, could do better for this patient to make them more well controlled. And it's something that in the past, I remember thinking, well, their eye pressures are fine, everything's stable, continue the treatment. But for you and I to be more aware that there's something more we can do to make it more well controlled and be mindful of the ocular surface. Thank you, Greg, for sharing that. Let's see here. Advance. And I'm just trying to advance here. There we go. Okay. So appreciate the feedback there. So my goal tonight is, as an overview, to cover 3 areas. What are we trying to focus on tonight? So what? Why would it matter? And then why I feel like it does matter. Now what? What can we do as providers starting tomorrow to improve the situation? So for the what part, just take a few minutes to talk about the introduction, talk about 2 common parallel diseases that we can, as optometrists, really be on the front lines to detect and to treat. and some goals for the lecture. So what? Well, we'll talk about 2 mnemonics, ways that we can, in my mind, improve early detection of 2 parallel diseases that can potentially affect the vision. And then we'll conclude with some case discussions, kind of a wet lab. We'll discuss some things and review questions. So for the introduction, by way of introduction, if you've seen from the lecture, so far there's 2 parallel diseases of dry eyes and glaucoma. Certainly prevalence is at least 30 million in the US. There's probably 5 times that many patients who at least have symptoms. They're just not diagnosed with dry eyes. But it's more than just a surface disease or ocular condition, but it's a lifestyle condition, affects the vision quality, vision stability. Proportion-wise, not as frequently detected as glaucoma, more than 3 million people. Both of these numbers are expected to rise, increase in frequency. So this is something that I feel if we can, as providers, detect it earlier, prevent that progression. Over 80 million people in the worldwide have glaucoma, and that's expected to rise to 111 million by 2040. So we can expect an increase in patients with early glaucoma or moderate glaucoma going forward. If we look at these other studies, up to 75% of the patients have dry eye disease, depending on the study. If you're older than 50, and 11% of glaucoma, they'll have dry eyes, and at least 60%. I bet you find in your clinic setting, nearly 60% of patients on topical glaucoma therapy have dry eye disease. That's probably a low estimate, very conservative estimate. To me, I feel like this is inevitable, that if they're going to be on topical glaucoma medications, eventually the patients will have dry eye disease, either from the preservatives or from the topical medications. So I'd say it's maybe a low number, but also I'd say it's inevitable. And here's a good example of another patient I saw last time. Falling for glaucoma, the disc hemorrhage, the superior rim thinning, but also the surface disease, the dryness. Again, I may have in the past thought this patient's stable. If that's the case, not given much attention to or concern for the ocular surface. And I think maybe due to time or interest or treatments available, many times would silo these 2 conditions. So even though they might have parallel diseases, dry eyes are more frequent, and we just kind of parallel the treatment or silo the treatment and silo the disease. But there's overlap. And many times we have to treat both conditions. In fact, if we don't treat one condition, it can make the other condition worse and vice versa. So there's importance of identifying it and treating it earlier. As another question for your poll, what are some risk factors for glaucoma-related ocular surface disease? So if these 2 conditions are inevitable and potentially inseparable, I call them frenemies, they love to be together. What are some risk factors that we could see as a provider that may cause this relationship to develop? What are some red flags we want to do to prevent this from developing?
So for this one, you can answer on the poll everywhere. You can scan that QR code. You can see, you can put in Austin Lifferth 070, or just put the response in the chat box. And Joe, you can police that for us if you would, please.
Will do.
So what are some of the risk factors for glaucoma-related ocular surface disease? Please use the chat box. This is not a poll that will be launched, or you can use the poll everywhere and put your response there.
So I was thinking about this, that these 2 conditions are frenemies. They love to be together, but they're worse when they're together. They worsen each other's prognosis and condition. We're out of our...
Yeah,
go ahead.
Yeah, it's kind of funny because I mean, I don't want to steal some of your thunder here, but you know, I speak for N.E.R.V.E. I've probably done already 8 to 10 dinner programs this year, and I speak to them, and they get an audience together, and I say, okay, what's the #1 cause of neurotrophic keratitis? And they're all like, oh, herpes simplex. And I'm like, it drives me crazy because every speaker out there wants to say, oh, herpes simplex, it's a rare disease. I'm like, no, you've created it. Think about it.
It's
How
true.
many in here are you treating glaucoma? You're the ones that created it. I said, I've been treating glaucoma in Pennsylvania for 25 years. I'm the one that's created it. It's, you know, it's these drugs. This, like you said, preservatives, the medications. And I always say, look, if you have a glaucoma practice, you've got an ocular surface disease practice. So I'm glad that you're here. That's why you're here tonight, to marry these 2 together. Quit siloing, make it a strategy for people when we're out there. So.
Yeah, well said, Greg. I can agree with you more, and it's so important. So follow-up question, when did you start to appreciate this connection?
Well, it was probably maybe say 6 years ago,
Okay.
go back. And then really the heighten came out when it was at the OGS meeting, whenever, the Optometric Glaucoma Society meeting, where we started talking about the front of the eye,
Yeah.
what are we doing to the cornea?
Yeah.
So maybe some suspicion, and in my whole kind of treat the patient, treat the body, treat the eye, think of everything together. Um, but that was before, we really had kind of like SLT out there as kind of a hot one. But we kind of brought it to attention, but really the OGS kind of helped cement it and really bring it to light.
I think I remember
And
that
I,
time. Yeah,
I
Joe.
also think that the advent of Travatan Z brought the conversation to the forefront
Mm.
because they're trying to take preservatives out. And in response, we had quite a bit of roll in on the chat box. Most people have implicated topical medicines. Some people were more specific when they implicated the preservatives in topical medications. A mention of diabetes, neurotrophic keratitis exacerbated by prostaglandins, preserved eye surgery, keratoconjunctivitis, cataract surgery, toxic response to the medicines themselves. Somebody also implicated the generic medicines, and that pretty much, along with age, kind of covers everything that has just rolled in from our audience.
And that's a lot of our patients, isn't it? Age, previous eye surgeries, topical medications. Those are great answers. I appreciate the response. I love it that each of you are aware of those different factors that could be risk factors for this glaucoma-related ocular surface disease. And Greg, I was thinking, I remember that time too when we had podium time for dry eyes at a glaucoma conference. There's a little subtle shift, realizing that we can do better, and with better treatment options available, I think we're seeing that maybe they don't have to be on drop therapy first. Maybe it's more towards the end. And I'll share that later on as well. But it's nice that we're, as providers, slowly thinking differently of how we can control our patients better. Greg, how long have you been practicing?
Ooh, I have 31 years. I just had my graduation date. So 31 years I graduated. So we can add another 4 years of that. So we'll say 35.
Yeah, congratulations. So 20 some years, 25 years later, you're realizing the importance of ocular surface disease among glaucoma patients. So it's great. We're all here to learn and to become better for that. So there's a great study done that talks about this. They call it the dual dilemma of dry eyes and glaucoma. This reality. It's if they have baseline dry eyes to begin with, that's a risk factor. So it makes me think that maybe for our glaucoma patients, as part of our testing, OCT, visual field, I'm starting to do osmolarity testing or a mini dry eye evaluation before I start on a treatment, so I can see what are their risk factors if there's some baseline ocular surface disease present. Or when they come back for OCT testing, we're doing a meibography or we're doing osmolarity, just so we can better understand the surface component to it. If they're taking preservatives, like you mentioned, the more glaucoma medications used and the longer they're using them for, the number of daily drops, these are all big factors. And then there's mechanical factors too, the blood pipe, conjunctival chalasis, post-trabeculectomy. And I think you're right. Whoever's out there, if you wanted to start a great, thriving, enduring dry eye practice, just go park it next to a glaucoma specialist. And you'll find a steady flow of patients coming in that you can help, but also grow your practice. So those are kind of by way of introduction, but here's the goals. Hopefully we've already done it already. We want to increase awareness of both conditions, increase understanding of these conditions, that they have a lot in common, that there's a strong association between these conditions. They love to be together. It's potentially inevitable, and challengingly, the challenge is that they can also be potentially inseparable unless we're careful and intentional to resolve that relationship and to increase understanding the damage when these two are together. They're worse when they're together. And this final cause, it doesn't happen overnight. To that point, I know it's simplistic, but all advanced glaucoma starts as early glaucoma. And all advanced ocular surface disease starts as early ocular surface disease. So if you see a patient with either of these two conditions, it didn't happen overnight. Somewhere along the line, things have been developing to cause these advanced stages. And I would say that both advanced ocular surface disease and endpoint, to me, is neurotrophic keratitis. I know we talk about osmolarity and staining, but ultimately, it's a nerve disease. So these are two nerve diseases, glaucoma and neurotrophic keratitis. So it all starts as early glaucoma. We have the spectrum. We know what advanced glaucoma looks like, moderate glaucoma. This is kind of a clinical gray area, sometimes with glaucoma suspect or early glaucoma. But it starts down here. And as providers, if we can get really good down here, we can prevent from getting to these stages. I'm thinking about this theory, this idea, as I'm working in my mind, of stage stabilization. Can we as providers do enough testing, enough treatment to ensure the patients stay at this stage? And that's dependent on what we do. Similarly, all advanced ocular surface disease starts as early ocular surface disease. And I'm sure there's some far better dry eye specialists out there than I am, but I feel like in my mind, the end stage of ocular surface disease, the common endpoint of all these different factors, is stage 3 N.K. with a perforated cornea, stage 2 or stage 1. And this is what we see frequently. In fact, sometimes I think we see it so frequently, we may get used to seeing it and it may not concern us. So we have these two parallel diseases. Fortunately, proportion-wise, these advanced stages aren't as common or frequent. Usually these NK suspects or glaucoma suspects are more common down here. As I mentioned, my interest is in trying to identify these patients earlier and to do the right test so we're at this area here, we can identify them earlier and keep them in that stage. Stage stabilization is what I'm trying to do. So to kind of show this relationship, to me, early glaucoma and stage 1 NK are both nerve diseases. They're chronic, potentially progressive. So we have to remember they like to keep progressing to the next stage. There's minimal symptoms for both of them. Multifactorial, and they're underdiagnosed. Greg, maybe as you're doing speaking for Dompe, they probably have talked about how it's kind of an orphan disease or a rare disease, but the more and more we realize it, I think it's just underdiagnosed is what it is.
Yeah, and that's one of the big discussions that we have is that, but because when it comes to the sales side, they have to talk because that's how the FDA did it. But I think from the medical side, geez, there's a ton of patients in our practice, right? I always talk about this medication, Oxervate was developed and approved in 2018. And I always just poll the audience, how many of you prescribed it? And kind of a handful go up. And I say, well, that's why we come to education. It's not because I'm great and this and that, so on and so forth. It's just that everyone wants to go out there and talk about how rare it is. It's not rare. If you're in an optometry practice, you have it. You just have to learn how to recognize it. And it's really because of these surgeries and medications and all patients with diabetes. And yes, simplex can cause it. And zoster, that's probably the lowest on my list that I see them. The medical side totally agrees that it is not a rare disease in an eye setting.
Yeah, I appreciate that. And I think to that point, each of us have probably seen it today. Whether we diagnosed it or not, we probably saw it. If we had done some additional testing, we would have recognized it. And as I mentioned earlier, they're frenemies. These two conditions of dry eyes, ocular surface disease, and glaucoma, they really love to be together. So as providers, we have to stop it earlier to prevent that progression.
So Austin, I'm not sure if you're going to mention it, but one way, if I know a lot of people maybe do rebound tonometry and maybe use the Aura, but most of us are still doing Goldman and putting the drop in someone's eye. So I said some of the times what happens is we lose, because our technicians will dilate and we'll miss that interaction whenever, you put a drop of proparacaine in a 22-year-old patient. They go, oh my gosh, that burns.
Yeah.
Then you put a drop of proparacaine in someone that's older and they're like, oh, this is going to burn. They go, oh, I didn't feel it. That to me is kind of a cheap neurotrophic keratitis test. Well, we do it all the time for glaucoma, right? We always check we put the fluoresce in and you put the drop in and we know whenever we're checking someone and they don't have all these glaucoma drops, man, that really burns. But a glaucoma patient comes in after a year or two using these drops. It's not that they got used to them. They are now neurotrophic because you put the drop in and go, oh, I didn't feel that. That's kind of a cheap, cotton wisp test. So
Yeah,
just
I
kind of a
think
little
that nice subjective test, the preparing test, it's a good way to identify that. And I think if Greg, if we can expand it out to our support staff, our technicians, kind of get a response that we put the drop in, the patient didn't notice it. But that's another level of maybe our support staff to identify it as well.
Yep.
Related to that, if I see these patients with all this apparent staining, I'm starting to, by the time I see the patient, they've already had their pressures checked, their eyes are dilated, so they're dry to begin with. So I'm not sure how much is from the drops or from the neurotrophic component, but many times I'll put some fluorescent and check for staining. If they haven't had their pressures checked, which I'll specify beforehand for them, I'll go ahead and check the pressure without an eye drop. And if I can have my probe on there and I'm adjusting it, that's another sign for me. So I just, another way to check for neurotrophic keratitis, for right or for wrong, I'm doing more staining, I'm doing more testing, sometimes without any anesthesia, any proparacaine. So I can check for that area as well. And we'll talk about some other tips of how to do that, but I think that subjective response is a great way to do it too. Yeah, great point. So we have these two conditions here, and our goal is to treat them early. I came up with some two mnemonics, and it's based on a book that I read not too long ago called Noise. It's a Flaw in Human Judgment from Daniel Kahneman. And basically he talked about how in any situation where there's judgment, there's noise, there's variation and variability. He talked about some examples of some insurance adjusters. 3 different adjusters came up to check on a roof. They all had different estimates, different reimbursements. They talked about judges giving out sentences, depending on the day of the week, the time of the day, whether they're more lenient or less lenient. If their sports team won that weekend, it was the plaintiff's birthday. So a lot of variation in the judgment and settings like that. And he just said that whenever, oh my screen, whenever there is judgment, there is noise, and more of it than we think. So I thought, how can this apply clinically? Well, one of the examples Daniel Kahneman also gave was about this lady, this person here. And you may not recognize the photo. Of course, I didn't. Virginia Apgar. If any of you have children, you may have heard of the Apgar score. And what was happening in the setting where in this time period in the 1960s, we were losing a lot of newborns because there wasn't a systematic way to detect problems. So she came up as she was an anesthesiologist, OBGYN anesthesiologist, and she came up with a mnemonic that the provider and the nurses, the support staff can look at, and in just a matter of seconds, determine whether this baby is healthy or if they need urgent care. And she came up with their APGAR score. So based on her name, appearance, pulse, grimace, activity, and respiration. By applying this, even now, decades later, it saved lives. So the newborn mortality rate increased. We had more babies surviving as they're given urgent treatment in just a few seconds. So I thought about this as a clinician. Is there something we can do as we look at the cornea or the nerve? Takes just a few seconds, have a systematic evaluation of assessing it, where it takes out this noise. So regardless whether it's Monday before lunch or Friday afternoon before we head out of the clinic, can we just look at quickly at our mind, assess these different factors to better assess the early signs of potential danger? Just as her APGAR score saved lives, we can save vision by having a systematic approach to that. And it came up with nerves and cornea. The last time I spoke with OEC, I did talk a little bit about nerves. And since then I thought, well, maybe there's one I could do for cornea. Joe and Greg, these are things my mind thinks about. What else can we learn about other mnemonics? So that's what we've come up with, nerves and cornea. So nerves will relate to glaucoma, and we'll review this in detail. But overall, what's a nerve appearance? Kind of the forest looking into the trees. What's the nerve appearance insertion? We're looking for the extent of rim loss, the amount, location, a pallor. R stands for retinal nerve fiber defects. V is all things vascular. E is buried at a zone peripapillary atrophy. And S is anything suspicious. Then do some other testing. And then cornea, what's the overall appearance? What factors are in this setting that could cause this patient to be at risk for neurotrophic keratitis? And O and R go together. So if there's oval-shaped staining or repeat or recurrent staining, I'd be concerned about NK. We do neurotrophic testing, find out the etiology, and we act. Both of these are good options to go with. For this here, Joe and Greg, we can decide which one we want to talk about. Maybe there's been a theme for neurotrophic keratitis, so I can jump to that one first if you'd like, or we can go with, in order, and go with glaucoma.
Well, Austin, you're the lead here, and we are
Yeah.
your support backup band. We're happy to do whatever you want. Just
Okay.
tell us what key to play in, and we're with you.
Maybe as we've talked about the cornea with the discussion so far, let's start in the front part of the eye. We'll go to cornea here first, and we'll
Okay.
start with this one for this mnemonic. So we're going to go to so what? We've learned about the importance of this potential relationship and our role as providers to diagnose earlier. Well, so what? Now, what can we do? Well, there's a simple mnemonic like the APGAR score that allows us to look at this condition and find out ways we can treat it earlier. And the first one is C. So look at the cornea, and as I mentioned, this is kind of like looking at the whole forest before we look at the trees. What do you see in this cornea that concerns you that would be at risk for neurotrophic keratitis? I don't have a picture of the lid, so I can't go that far out on this picture. But there's anything that shows up in that screen, Joe or Greg, that concerns you for NK?
I think just the extent of the epitheliopathy.
Yeah, pretty diffuse.
I actually saw this very same type of person today, bilaterally, 12-year-old.
Wow.
And it was really acute because he had a bit of a problem. His mom took him to the strip mall ER, or the doc in the box walk-in clinic, and their drug du jour was gentamicin.
Okay. It killed everything.
Yeah, pretty much. I mean, I would like to help them, drag them into the 90s and maybe get a fluoroquinolone, but jeepers.
Well,
And
maybe
heck, Greg and I used that when we were in training, when we were in 3rd grade of optometry school.
maybe
At least it was
cover
better
that.
than sulfacetamide, so we'll
Yeah.
just give them that much. So
Well, that's why they give them prepare can go with it.
that's right.
Well, a lot of SBK. Also, you can see hopefully this faint LASIK scar here. So we know this patient has had LASIK in the past, as Wendy mentioned, appropriately so. Any previous eye surgery, especially LASIK, can be a factor for it. We'll kind of dive into that. Again, O and R will go together. So if you've seen any oval-shaped central and inferior central staining, usually it's inferior central staining, or if it's repeat staining. So if you have a patient keep coming back and they still have SBK, it's not going away, I'd be concerned about neurotrophic keratitis. If you see that, then do some corneal sensitivity testing. We'll talk about that beyond like the proparacaine test. N stands for neurotrophic testing. E stands for the etiology. So we have to think, well, which of these things, of all these different factors, could be causing it? And then A is to act. What can we do? Push the button to help regenerate these nerves, restore the nerve function, help promote healing. So for a C, the corneal environment, this is all, we're dealing with all these factors. This is challenging. So the nice graph from the DEWS workshop there talks about all these different factors that can contribute to a patient's dryness. Hereditary components, the nerve damage from previous surgery, this gut dysbiosis. In my dry eye clinic, I'm starting to ask more about their gut health, their foods they're eating. Can ask about the regular bowel movements, all these different factors, the environment, eye accessories, eye surgeries are all part of the corneal environment. So if we see this recurrent staining, we're thinking we're kind of taking a step back. What do we see here that could be a factor for this condition? And I like what they said, gratefully. They said the management of dry eye disease is complicated due to its multifactorial etiology. Look, all these different factors could cause it. This aspect of determining the major causative factors is what's critical to the appropriate management. So as providers, we're detectives. We have to figure out which of these factors, or all of them, or many of them, could be causing this dry eye disease. And then add to that, not only their personal history, but their environment. Kind of working our way out of the indoor activities, outdoor allergens, the air humidity, air flow, air quality. All these different factors are always around us for the environment, causing it to be dry. So we can be successful in one area of the treatment, but if there's other factors in the environment that are always around them, it's going to limit their improvement in symptoms. So this lifestyle impact is significant. something we're better appreciating. But I feel like that's all part of the C, the corneal environment. So today I had a patient, and it was a longer discussion, longer history of tell me about what you do, where you do it, tell me about your airflow in our dry eye clinic. She's had been on several treatments, so I figured we have to step back and look at some other factors that could be causing this dryness. When we had our mask, this is a big factor as well, but we still see masks every now and then, causes this MAID, mask associated dry eye, another part of the factor. And then in addition to the corneal environment, we can, as we have taken the big picture, let's kind of zoom in and look at the lashes. I think this is another factor that we're starting to better appreciate now that we have a treatment for it. We can better be mindful of any collarettes, Demodex component, in the associated telangiectasia. Look at this biofilm. That's hard for the cornea to have good, healthy tears when there's so much inflammation, or this biofilm blocking the glands, leading to styes and dry eyes. So if I say,
So Austin, I'll feed off of that a little bit.
yeah, that's great.
You just talked about the gut dysbiosis. I look at this as you have lid microbiome dysbiosis,
Oh,
right?
that's great.
So yeah, so and you look back and if these are glaucoma patients, think about what's in there. You have BAK. BAK is a great preservative. So not only are, the drops are messing up the pH, and then you got a preservative. When I see these patients, I'm looking at them going, what, we talk about, so we have different, microbiomes throughout our body. Gut is the big one because it creates the leaky gut. But this is just another one. We have an ocular, microbiome. And so why is it disrupted? Is it the glaucoma meds? Is it the BAK? Again, it's multifactorial. It becomes more of a strategy rather than linear and binary. But that's a great picture there to kind of highlight all of that.
Yeah, great example. There's a gut y-axis. This is the eyelid y-axis. It connects to it. And in the context of what we're talking about, before I prescribe a drop, I'm now starting to look more at the ocular surface and the lid component. I mean, how many times do we consider our drop therapy based on what we see for the lid evaluation? So I think this is almost part of our glaucoma evaluation, or should be, for it. So we're still, if they select drop therapy, I think a lid evaluation is important to do. All part of the corneal environment. Thanks, Greg. I appreciate that. And it's real easy. It takes a few minutes. Here's a patient with moderate dermatochalasis, and I just had him look down, and there's a little Demodex hiding up there, enjoying their their lashes, their lids, their glands. So have them look down. We'll be surprised to see how much Demodex there is there. This really is an easy way to treat it, and I'll talk about that in just a moment. But if we can clean this off, and many of you have found it as well, not only do the lashes look better, but the glands look healthier, and the eyelids don't look as red or inflamed. So doing Lotanlayer 2 times a day for 6 weeks, safe to take, very effective. It's from Tarsus, and this should be something that as a optometrist we should easily, comfortably prescribe to clear that off. It's going to make their lids a lot healthier. This Demodex loves fake lashes. And if we can, even in the office, clean them. I'll use a debrider to remove that biofilm. But if we can clean off the lids and lashes, that's a big part of it. I feel like dry eyes begins with the lashes. So the lashes and the lids. So clean those off. And then as part of the process, as we evaluate, then do some lid expression. A dynamic evaluation, not only we look at the lids and lashes, but have them maybe push on the lids to see the amount of meibomium expression, the quality, is it turbid and cloudy, or more toothpaste-ish, or is there none at all? So this is an important part of the process, helping us better understand, well, what's causing this dry eyes? What are the drivers for this? And that's really what the new DEWS 3 workshop talks about. We're looking at drivers. So we see different signs. We think, what's causing this dryness? It's more clue-based, and so we can treat it. We don't have to go by stages. And just push on the glands. You'll like this, Joe. Look at that. Kept going. Anyway, I just kept pushing on the gland, and this oil kept coming out, almost toothpaste-like. Afterwards, she said, boy, that felt really good. I was surprised. I thought it'd be hurting her. But how can she get good to meibum when it's that thick like that? So these are factors that definitely are cumulative, and they gradually cause more and more discomfort. for those on the West Coast, hope it's around dinner time for you. So this is a great time to maybe look at this slide for you. Any comments, Joe? I see you looking in on that one.
No, I think they're great pictures. If you've taken these, you did a fantastic job. I'm just thinking that if this happens to be an advanced glaucoma patient, it could be actually deleterious. You squeeze out the glands, but raise the impression, and snuffing out the field.
That's I like how you're thinking. That's right. Be mindful of that part of it. So look at the glands. Be mindful of the pressure. We do have meibography as a way to do it. Sometimes though, if you don't have meibography, you can almost do this poor man's meibography. Look in the lid architecture and see if it's kind of atrophied down, or you can even pull the eyelid down and you can see how this area here is missing, correlates with this area. So we need meibography. It's great to have, but if you don't have it, as providers, we can just do this poor man's meibography and better assess the gland function. Again, an important first step before we prescribe any drops to do the just a brief mini dry evaluation and make sure these glands are working better for the patients.
Hey, Austin, somebody asked, do you recommend meibomian gland expression frequently?
I do. I like to, when they come in for the evaluations, we do it. When we do the low-level light therapy, we do it afterwards. But at home, I just have them do blinking exercises, a heat mask, and blinking regularly. But it's not a bad idea to keep them working. My thought is a slow drain in our house clogs up quicker. So if we can have glands that are working better, there's less chance of getting clogged or slow, so better function. I think, well, if we don't use them, we lose them. So keeping the expression going is good to do.
And I like the fact that you mentioned a heat mask. I think we all need to get beyond the whole idea of baby shampoo for lid scrubs and hot wash rag for hot compresses. We got good
Yes.
products out there, and I tell people, the wash rag just doesn't work. It's not good. Let's use a mask with beads that you can heat up and keep warm, and it's pliable. And we got to get away from the old-fashioned ways of doing it.
Yeah. You talked about using certain medication antibiotics when I was still in school, but I remember I think we did Vaseline for these poor Demodex patients, hoping that would take care of it. Well, there's better ways we can do it nowadays beyond just.
Well, we actually use the Vaseline for Demodex's big cousin psoriasis,
Okay.
pubic louse, because we didn't really even know what Demodex was until relatively recently. But if you can actually see the organism, you're not dealing with Demodex.
That's great, great, great quote. Thank you. So I think it's important, as Joe said, there's better treatments now. And if we're not prescribing these advanced treatments to really get the patients feeling better, now's the time to start doing so. I've never had any patient come back who I've prescribed on the Lotulelei for tarsus, and the lashes look a lot better. And the home therapy is helpful to do. So yeah, we're talking about the lid evaluation. You don't need meibography. It sure is helpful. Just doing the poor man's lid aversion is helpful. To me, meibography is a lot like having OCT. Every time I've done it, I've realized how much I better appreciate the gland loss or the gland truncation. But it's nice to at least estimate it with something like this. So as we're working our way in, look at the staining pattern. Moderate staining. Interesting pattern is more inferior. And sometimes when it's inferior like that, that may suggest an incomplete closure. Maybe incomplete, maybe an ectropion or partial blinking. So I think part of it, just doing the simple Corby-Black test, Corby-Blackie test, have them look down, put a light on the top lid. We don't want to push a lot on the lid. That way might artificially raise the eyelid upward, but we're looking for this glow down here. If patients say their eyes feel most dry in the morning time, this is when we need to make sure that's when they should feel the best. So just a quick test right here helps us better appreciate if there's any closure. And I find that patients who have dry eyes in the morning due to incomplete closure, also as the day goes on, their eyes get more dry. They may have partial closure while they're sleeping, but also as the day goes on, they just don't blink all the way. They're partial blinkers. So I think those two go together. That's an important mention for them. As shown here, just as partial blinking, you can see where this line is drawn here. So they'll blink really well here, not all the way down here. And this is where the dryness is. So partial blinking can certainly cause dryness, so much to the point where it can become neurotrophic as well. So it's an important part of that evaluation. In fact, it gets so dry, they just lose that reflex to blink. We don't have the nerve signal there, the trophic response. Here's another patient with central staining due to moderate ectropion. So we're also looking at the corneal environment. There's a mechanical component to it. It's harder to tell sometimes without staining, but maybe you'll be able to appreciate this conjunctival chalasis here. With staining, you can see how it just disrupts the whole tear film. So this would be like if you have a gutter that's clogged, then the tears would, or the rain would go over the gutter, but in the eye, the tears just drain over it. So we don't have a tear reservoir anymore. We have this conjunctival chalasis. This needs to be treated with radio frequency or with your surgeon to tighten that up. Honestly, restoring that tear gutter helps, that tear reservoir helps with the symptoms. If a time to consider this is if the patient comes in and their osmolarity is in the normal range. If they have normal osmolarity and dry symptoms and watery symptoms, be mindful of this mechanical component to it. Additionally, if they have EBMD, sometimes this is hard to pick up. But if we do staining, we'll be able to pick up those areas of dystrophy sooner. And this is like to tell patients like some bumps on your windshield. When it's bumpy like that, the tears just don't go over as smoothly or as evenly, causing a secondary dryness. So all these factors, in fact, these two slides are showing the importance of staining. Just put in a fluorescein strip in and stain the pattern. And then we also look for inflammatory causes, filaments, and then also tear breakup time. So look at the staining pattern, the location, but also the tear breakup time. Have them take a blink. And interesting, this patient didn't have a lot of dry eye damage until I had this patient open up their eyes and keep it open and match their symptoms that with prolonged computer work or reading, their eyes felt more dry. So still pretty good surface, but as time went on, it got more dry for us. And let's see if this plays here. So I just had the patient blinking to see within a few seconds what a rapid tear breakup time. So Joe or Greg, how would that affect our refraction, our contact lens fit, our vision stability, our comfort?
All the above.
Yeah. I think this is something a clue that if we do the refraction or the support staff is taking their vision and they say I have to keep blinking, that's a clue as well. So the more we can involve the support staff in factors like this is a better way to detect this fluctuating tear. So fluctuating vision, but also dry eyes. So I mentioned earlier though that with staining, we see it frequently. We're not sure, but how much does it concern us? So here's another poll here. When are you concerned? How much staining concerns you? We have a little bit of staining here, in grade 1, 1+, grade 2, 2+, dense, diffuse staining. I am concerned with any staining. So this would be analogous to when you're concerned with nerve fiber layer loss. Only when it's moderate stages or advanced stages, or is it just when it's in the early, or are we concerned with it when it's early stages? So I've started to be more mindful that if I see staining, that's not normal. There shouldn't be staining there. There's some underlying process, some underlying process that's caused damage from one of those corneal factors there. So any thoughts? When does it seem to bother you? When did you start treatment?
They're rolling in on our end, just so FYI. So
Now it's a somewhat humorous story. A few weeks ago, my wife called and said that our downstairs ceiling was leaking. So I went down there, was just a little drop. Little drop coming down from the ceiling between the rafters there. And my first thought was it's just a little drop. But my second thought afterwards, that's not normal. It shouldn't be like that. After breaking it away, it started to drain more water. We got the water turned off, still fixing the ceiling. But even a little bit of drop isn't normal. A little bit of staining isn't normal. And I think if we can be aware of that, that can help us with our evaluation and be more proactive in our treatment.
So I am concerned with any staining in the poll. I just have picture 1 through 5. The winner is picture 1, so it sounds like
Oh,
people
good.
are concerned with
Yep.
any staining, but so that was 42%, 38%, 6, 4, and then 10.
Good.
But I don't have any staining in the polling. So.
Thanks, Greg. And I think you're right on. If we see some staining that needs some sort of treatment, and that's what I was trying to get across there, to not be content with some mild staining until it gets to be more significant. Remember, we mentioned earlier that any advanced disease starts off as early disease. This is the early disease for us.
Leave that picture up, and I just kind of always like to point out cornea dynamics. I've done this enough at the live meetings and throughout the different webinars, but you have a great picture there that I'll kind of highlight what's happening here. And one of the questions I usually like to ask the audience is, what is the flow of fluid through the cornea? Is it front to back or back to front? And then people look at me like, when I do it, like, Doc, what the heck? Like, did you bump your head last night? Like, just what is the flow of fluid through the cornea? And the answer that I'm looking for is front to back. And and Joe's heard me give this analogy, is that if I have a vacuum cleaner here and I put my hand over it and I'm trying to suck up particles or paper clips or dust or whatever, I say, man, this vacuum cleaner really stinks. It doesn't work. You say, Doc, take your hand over off of that, and now you can suck up the dirt and
Oh.
debris and the paper clips and so on and so forth. The epithelium is the seal of the cornea. And what happens is when you break that epithelium, the endothelial cells keep the cornea deturgest. That's our fancy word, 78%, so on and so forth. And why I'm bringing that in is if you look at that picture that you have up, Austin, I'm not sure if you can use and find out where I am, but those inferior coalescent, if you can kind of see how that fluorescein is being sucked in, that one right there and that one there, that fluorescein is being pulled into the stroma, sucking things in, right? So the cornea, the eye at least has a great immune system, but to me, that is never good to have staining, because whatever's in tears, not that best septic, and not that it's like a septic tank. And that's why, like, if we have meibomian gland dysfunction, I always ask, where does the marginal ulcer occur? 12, 6, 9, or 3. Everyone usually says about 6 o'clock, because you have that foam sitting down there. It breaks down the epithelium, and then things suck in, you get that marginal ulcer. So this cornea and all those corneas are at risk. And the other analogy I say is, look, if I have my arm here and I smear some bacteria on it, am I concerned about getting an infection? Most people will say no. But if I fell down in the parking lot and scraped this one and I have an abrasion, which is what this cornea is, have an abrasion on my arm and smear that bacteria, yes, that epithelium of my skin is broken. I'm at risk. This eye is at risk, and you can see that sodium fluorescein is being pulled in.
Yeah, that's a great point. The barrier is gone, and it happened as early stages all the way up here, and it's more advanced stages out there. So the barrier is gone, and I think that's the point. Great way to look at not only concerned about NK, loss of vision, but also infectious keratitis. Yeah, perfect.
And I think another cool thing to think about NK is remember, that's a disruption in the trigeminal nerve. And we always talk about cranial nerve number 2 having an APD, an afferent. Remember, all the cranial nerves, all of our cranial nerves have an afferent and an efferent. So the afferent is that the organ talks to the brain, the cortex goes through all of that, and then you get an efferent response. Well, to me, when you see things like this in neurotrophic keratitis, it is a corneal afferent defect. It cannot signal back to the brain to give the efferent defect. Remember, the nerves and the epithelium play together. That's where you hear neurotrophins, right? The neurons giving nice peptides to the epithelium tissue. You're not getting that efferent response because the afferent response is broken. So when I see this here and you do neurotrophic keratitis, I think it's a corneal afferent defect.
I haven't looked at it like that before. I love that explanation. I have told patients that dry eye disease is a nerve disease. It's an autoimmune disease. It's a multifactorial disease, but it's also a nerve disease. So I think you're right. It's an afferent defect. That connection's been lost there. And it can start in early stages. So yeah, appreciate that insight. That's great. So we talked about the C for the mnemonic memory. As providers, remember with APGAR, take a few seconds to look at it. What do we see? The C stands for the overall corneal appearance, the environment, the lifestyle, the health, lashes, lids, expressions, staining pattern, tear breakup time. The next one is OR. They go together. When is stain significant, as we talked about? If there's any oval staining in the inferior central area, oval shaped, or repeat staining, I'd be concerned about that. So we talked about the different spectrum. If it keeps showing up in this inferior central area, oval shaped, be concerned about NK. And then how do you test for neurotrophic keratitis? So we see this recurrent staining, we see the different factors. How do you test for it? When? On whom? And I think as we test more, we'll find more as we look at this condition. I did ask AI to help me, well, what's the latest, or how would you draw a picture of patient doing neurotrophic keratitis? And Joe, I'm not sure how you do it down at Stanford site in Florida. This is something that's new up here in Indiana. Basically, you can have the patient take their lens out of their glasses, use a Q-tip, and touch the outside part of their eye, according to AI. There's better ways to do this. So
Well, actually, I am happy to see this because it tells me that we will have jobs for the foreseeable future, and we're not going to be replaced by AI.
Yep. Actually, that's right. I've had some patients come in for a dry clinic, and they've already pre-assessed or asked AI, what do I need done? So this is good. This is job security. You're right. This is not the way to do it. It gets the right idea, though. Other ways are just the corneal sensitivity testing. There's a great website. Greg talked about DOMPE. They've done a great job of increasing awareness of neurotrophic keratitis. I have no financial disclosure with DOMPE, but this website, it's called N.E.R.V.E.S, a little play on words, is really wonderful for patients. And if I see patients, they come in, we show them the pictures of the dryness. I say, well, you're not fit. We do this neurotrophic testing, however you want to do it with the proparacaine test, a cotton wisp, dental floss, tissue. But this is helpful for them to review the different symptoms, stages, and signs of it. So I'd use that as a resource. It's very patient-friendly, a great way to increase the awareness of it. But I'd recommend, if you see those signs we talked about, to start doing NK testing. There's some standardized tests like the Braille anesthesiometer, but more chair-side, something like this is helpful. I don't do the dental floss as much because it leaves like a little toe mark. My concern with this Q-tip is it's, by the time I tease out the wisp, I've used my fingers, even though I've washed them. I'm not sure how clean that is. It might cause a little bit of irritation, so I prefer not to do that either. But I do like the proparacaine test, just some sort of test to see if there's a decrease in that, if there's an afferent defect there. So the next part of it is etiology. So we've done the testing, we figure out these are the different causes. Which of the factors are affecting homeostasis? When I see staining, that means a sign there's loss of homeostasis. Something's causing that imbalance. And we have to find that balance again to restore it. And then as part of that etiology, look at all these different factors. Infectious, that's to your point about simplex, zoster. Interestingly, Greg, you may have heard this as well, but I've seen there's an article that talked about this neurotrophic keratitis for herpes simplex. It doesn't take weeks or months, but it can happen after a few days of simplex. And the fellow eye has decreased sensitivity as well. So I'm starting to test that as well. I thought that was interesting that, one eye is involved, do neurotrophic test on the other eye. Any ocular surface disease. So that's why I feel like all ocular surface disease and a common endpoint is NK. So chronic blepharitis or chronic lens use, tropion. Any surgeries, as we mentioned before, any medications. These are our glaucoma ones. Any health conditions. A lot of these are our glaucoma patients. They might be old, elderly, have diabetes. They're on treatment, and other rare ones like that. So a lot of different factors to consider. The common endpoint is dryness and the neurotrophic component. So when I see these patients, my goal is to do three things. I want to help them feel better if there was pain, certainly help them see better. Many times the patients with neurotrophic keratitis don't necessarily have any symptoms, but their main symptom is their vision's blurry. They want to see better. And I want them to look better. So clinically, I want that staining to be resolved. So we do the different treatments for it. A is aim and act. So we act on what we're seeing, find the different causes, and then treat it. So some examples. One is let's clean off the lid component, maybe with lid debridement, home cleaning, in-office cleaning, micro bluff exfoliation. We can do a micro bluff exfoliation, clean them off the lashes really well. Here's before, here's after. We talked about Latalier from Tarsus 2 times a day for 6 weeks. That's 2 full life cycles. It works great. And Greg, you have to correct me, but I think it's 60 or 70% of patients a year later still were looking good without needing a retreatment. So that's amazing results for medication like that.
Yep, that is the number. Yep, correct.
So
Yep.
very effective, very safe, and long lasting. You can do in-office therapy. So IPL. And we'll pair with low-level light therapy. So we're trying to, this photobiomodulation, kind of like glaucoma, the more that we can do for the patient in the office, the less things they have to do at home, factors that can affect their adherence. And just some slides that show how IPL helps decrease inflammation, increases circulation, increases meibomian. And I found in our practice that they pair well together. Like decrease inflammation, increase meibomian fluidification, they affect the epithelial turnover, photobiomodulation, and can be antimicrobic, anti-inflammatory. So I found it helpful for us as well. Here's some examples of a patient who had IPL and low light therapy. Remember we talked about the importance of the glands. Well, some expressions, but cloudy. Not many expressions on the other lid, more inflammation. After the low light therapy, better expressions, less telangiectasia, less rosacea. So great results. Here's another one. I was surprised this atrophic lid component there kind of scarred down. And then after IPL and low light therapy, what glands they did have started working better. And patients feel this too. There's just less inflammation. When there's less inflammation, things work better. Not many glands to begin with, but the glands they did have, I'll show you, start working better. Significant rosacea. This may have been a glaucoma patient now that I think about it. Maybe that'd been my fault from the topical PGAs. And then here's what it was before. Then after IPL and low light therapy, a series of 4 every couple of weeks. So it shows big improvement. So wherever you're at, as providers, depending on where you're at, try to work with your other optometric colleagues and see if there's a way you can do some in-office therapy. It shows big improvements for these eyelid conditions, a factor for the dry eyes. Here's one that's just a few glands, but if the glands are working well and functioning well, have a pretty smooth surface. This is like advanced glaucoma, they're just down to a few nerve fibers. These poor glands, that's all that's lost there. And sometimes we might have pretty good gland function, maybe a little bit of truncation or loss. It's more low tier quantity. So treatments for that, see the moderate conch staining. This is inflammatory. We want to decrease that inflammation. And factors that can cause this are the same things that can cause the neurotrophic component to it. I like plugs. I think with the right timing for the right patient, they can make a difference. I think this would be a good poll question. Some people prefer not to do plugs. Some people like plugs. If the inflammation is decreased and there's better, less redness, less staining, I introduce some plugs for that. Jill or Greg, any thoughts on that? What camp are you in?
Well, I'm in a camp of using plugs. I don't get too much into the camp of that I have to reduce the inflammation and it's going to build up and all that. But again, I work right down the street from an 8-man woman rheumatology practice. So I see Sjogren's and mixed connective tissue and lupus patients, and just getting the plugs in and getting them comfortable and starting to reset, getting that eye wet is super helpful. So I still use plugs that are out there. I know that the drop people that they want to they want to get the inflammation down before getting the plug. I agree with it, but you can't do everything linear and binary in medicine.
Yep.
And if they have hardly any tear prism, you got to use a plug. Sorry.
Yeah, I do plugs frequently, but I do intracanalicular dissolvables every 6 months. We don't really use the silicone ones very often. In fact, we can't give them away. And we're getting a little bit more into, into lacrophil in the practice.
Yeah.
Because, lacrophil was actually invented at Center for Sight by our oculoplastic person.
Okay. I haven't done lacrophil. That's something I'd like to try. Both have advantages. I did this silicone plug. Sometimes if the patients are younger, lids are tighter, these can be pretty irritating. They rub on the conjunctiva, but yeah, lacrophil is a great
Well,
option as well.
Austin, I would encourage you, please, to use lacrophil as much as possible because the inventor, our oculoplastic surgeon, his jet is getting old, in all fairness.
Okay. I'll remember that. Thank you, Joe.
So I do
So,
lacrophil, and I'm on the inpatient care 2 days a week. I'm there Monday and Tuesday, and I probably do lacrophil out of those, 8 days, probably, maybe every other week, if not every third week. So it's become, that's kind of my plug of choice, if you want to say, that's out there. Patients really enjoy it. They come in for their refill at 6 or 9 months. Um, so it's been pretty cool. You don't have that irritation that you're talking about.
right.
So lacrimal closing, I will do, and either lacrophil or I don't like cauterizing though,
Yeah.
unless they're like Sjogren's and I've plugged them up and I just can't keep them in, then we'll maybe cauterize upper or lower. But I still like lacrophil or the permanent plug.
That's great. These are great conferences. It's fun to learn from colleagues, different situations, different applications. So I appreciate that. I'll check out lacrophil. Give it a try there. Um, Patients where this is an example of using a steroid to calm down where they're staining like that before and after the plugs. And I found bandaged contact lenses can be a helpful tool depending on your setting. This can be effective. I'd use an antibiotic if there's something like this, like moxifloxacin, it's preservative free. That can be a way to protect if there's more of an exposure component. But cryopreserved amniotic membranes sure are helpful. Amazing results. Every time I've used it, kind of like Lotanlayer for Demodex, every time I've used it, it's worked great. And there's some that are ringless now. It's called the CAM 360, also cryopreserved, that have equally beneficial results and is indicated for stage 1 NK. So I think what they're trying to do with biotissue is help us realize that any staining matters, so let's treat it earlier. So this is a great way to help improve the situation. And these have regenerative properties as well. So many times it can jumpstart the nerves. Maybe while in the process of ordering oxyrvate, then we'll do the Procara there. So let me kind of show you a patient of what we found here. Here's a new patient for dry eye evaluation. She's had a history of cataract surgery. Actually, she kind of looks like our NK patient now that I look at it, where we're doing NK through her glasses.
You just have to close her eye, take her lens out,
Yeah.
use the cotton.
You know, it's kind of strange. A lot of these patients are elderly women. So as I was asking Anne to create an image, unfortunately, it hopes I don't have a type for elderly women of pictures that are showing up there. But that's what it shows. 74-year-old female, history of cataract surgery. She's on lifitegrast. And her symptoms are burning, redness, watering, tearing, and eyelash matting. Pressures are normal, and osmolarity elevated, more in the left eye than the right eye. So what things do you see that concern you here? We said, let's start at the overall the forest before we look at the trees, the overall appearance. Can you see this maybe 1+ Demodex or grade 2 Demodex, almost every lash or every other lash? There's moderate telangiectasia. And it's almost this atrophic appearance as well. So as we do this lower lid aversion or on mybography, you can see there's moderate to significant nasal gland loss and truncation. So certainly contributing to her dry symptoms. We talked about the staining, making sure we stain. She has corneal dystrophy and a low tear quantity. So a lot of drivers, like when they talk about induced 3 of this dry eyes, and many times we see all these things they need to be treated for. We have to prioritize what's going to make them feel the best, the quickest. How can they feel better? How can they see better if that's a factor? And how can they look better? And as part of the dry evaluation, many times my dry patients will be on a steroid at some point, either for induction therapy or for flare-ups. Flare-ups 2 times a day for 2 or 3 days is all I do it for. But I always do a nerve evaluation as well, and making sure they're not at risk for glaucoma, as well as checking their eye pressure. And you can see in this patient here that there is some questionable inferior thinning in both eyes. Shows up on the OCT scan, superior-temporal and inferior-temporal thinning. And I found, always put this OCT in the context of the clinical exam. The OCTs commonly have artifacts. And we know that already the scan isn't very reliable, just with the smaller nerve appearance and myopic appearance, that temporal RNFL pattern. So it's not as reliable, but it does show some thinning, and it seems to correlate with what we're seeing here and here. So I always put the additional testing in the context of the clinical exam. Similarly, any functional testing. So here this patient came in for a dry eye evaluation, and it turns out, because of the different testing, just because we're looking for it, did show some moderate RNFL loss and advanced glaucoma in the right eye, moderate to advanced in the left eye, because it's good nerve centration there. So how would you treat this patient? Now what? And we think about whatever treatment. So she came in for dry eyes, but we also see that she's a patient who has glaucoma. Is the treatment going to be sufficient? We want to make sure we treat the glaucoma so it doesn't progress. Will it be tolerable with her underlying dry eyes? Will it be sustainable? We can give her a good medication, but maybe it might make her dry eyes worse. Is it affordable? And is it needed? So those are the things I ask for the patient every time I see them as I assess their target pressure range. How would you treat this patient for that? Any thoughts, Greg or Joe, or with these 2 challenging conditions, the surface disease, moderate to advanced glaucoma, where would you start?
Joe, you want to go? You want me to go?
Why don't you go first?
Yeah, so I mean, that it's a great case, Austin, here, because you got a person that has, ocular surface disease. We know we're going to make it better. I'm sorry, we know we're going to make it worse once we start introducing a prostaglandin. You can try even go like IUSA, but you're still going to create some ocular surface with that just by introducing the medication. If you're going to do anything, quickly, obviously it'll be drops. In our area, it's hard to get in to see a surgeon within 3 to 4 months. That starts throwing in some issues of SLTs and Cohook dual blades or minimally invasive glaucoma surgeries. So now you've got things to weigh out here. So I think you have to have a strategy here of short-term treating the ocular surface condition aggressively, treating the glaucoma with as little topically, with a game plan of maybe surgical intervention, as you're seeing over what happens over the next 3 or 4 months. So it's a great case here. We see them quite a bit in the practice because, patients come in at this age and they're looking for dry eye. And then I just had someone come in the other day, they saw something on TV, diabetes and advanced glaucoma. So,
wow. Yeah.
yeah.
So it makes
Yeah,
it,
a number of people in the audience are mentioning SLT. If you go back, let me go back a little bit. Let me look at the information again, if you could.
Sure. So here we go. 240, 250. Normal pressures at that time, just higher osmolarity. She already had cataract surgery, so she is pseudophakic. Currently on lefidogrest. Lid margin disease.
Got a lot of lid disease. Got to treat a lot of surface. This is a patient that we've got. First off, we've got to address the blinding disease, which is glaucoma. We can't favor a debilitating disease over a blinding disease. So we have to take care of that. This patient is at some degree of risk, even though she is she's older, she has a fair amount of field loss. But this is a person that I would try to treat with one medicine, but I would also use platelet-rich plasma on a patient like this. I would also treat the lid disease first off, the lotilaner, if you got any Demodex, get rid of that. There's some telangiectasias to the vessel, so there's glandular issues. I would probably treat with azithromycin, 500 milligrams, 2 tablets once a week for 3 weeks. I would put the patient on platelet-rich plasma tears.
This is great. I mean, it's just like if you had a room full of glaucoma specialists, they'd all treat the patient differently. The panel of dry specialists would all treat them differently. I think that's a great approach. The goal is the same. We want to prevent this blinded disease from getting worse, but we also want to make the patient feel better. And the sooner we can do both, the better. So those are great perspectives for it. I think we did do N.E.R.V.E, lateral for help with the Demodex. I've seen that does help decrease the telangiectasia. That's going to improve that part of it. I did do a switch from lifitegrast to cyclosporin 1%. BID, I'm getting great results with that one, which works pretty well. We didn't do anything with this EBMD. Maybe we did a mirror at nighttime. But I think I did recommend SLT for this patient to help out with the pressure as initial therapy. But those are all good answers. We're trying to find what's sufficient. We won't want to be, we want to make sure the pressures are low enough. Prevent that
Go
blind.
back one slide there, Austin. I just want to point out that visual field to the audience here, and that's it's a great visual field. Let's just assume that it's reliable. And if you look at that left eye, if just want to point out that mean deviation is minus 7.12, and your pattern standard deviation is 10. So, I always use 0 to 5 as mild, anything 5 to 10 as being a moderate visual field defect. And then anything above a 10 is severe. So we're already into the moderate stage. And then when you look at the pattern standard deviation, it tells you how localized it is. That's a big number. And if you look right along that horizontal margin, you got some minus whatever, 28s, and 20s, minus 20s up there, and that right there. Those are some pretty deep. So like Joe said, we got ourselves a pretty decent glaucoma here, based upon this visual field. I mean, we can get some structural damage before we get functional damage. We've got a pretty good functional damage on this 24 or 30-2 that you have done on this page 30-2. And, we've got a pretty good glaucoma here. So yeah, we got to address both, but this is a pretty good glaucoma case.
Yeah,
And Justin, somebody asked me in the chat, why do I use the azithromycin? There's a fair amount of telangiectasia of the vessel, telangiectatic vessels on the lid margin. That tells me we have some lid disease. Maybe there's some degree of rosacea. And I don't use doxycycline. Azithromycin, 500 milligrams, 2 tablets once a week for 3 weeks. So 6 tablets is as effective as using 100 milligrams of doxycycline BID for 6 weeks. And you don't have the risk of stomach upset or the photosensitization. So it's very easy to help get those lids and those glands back into order. So that's why I use azithromycin. But what you can't do is just artificial tears. And you mentioned lifitegrast. How was the patient using it, Austin?
BID 2 times a day.
Okay. Too many times I see lifitegrast and cyclosporines. They're used PRN. They equate artificial tears. These are a strong artificial tear, and I'm going to use them as necessary. And when I see that, I tell them, look, either use artificial tears or make a commitment to using the medication twice a day as recommended. You can't dabble in these scripts.
Yep, well said. We know that glaucoma adherence is really poor with topical medications. I thought as I get in this dry eye space, because I'm trying to treat glaucoma better, to learn more about dry eyes, I thought the adherence for dry eyes would be better, but it's true. Many times they're not doing the treatment regularly, consistently, or for sustainable time like that. So you're right, they'll take drops for treatment for glaucoma, drops for pressures, drops for dry eyes. Yeah, so great cases, and that's what we're trying to answer is all those different factors. We want to address our concerns, of course, but we also want to prevent further blinded disease. Just like dry eyes has a vicious cycle, so does glaucoma. One thing I've found and better appreciate, and this is why I'm trying to use less topical medical therapy, is once we put a patient on drops, it works, lowers the pressure. But if it's preserved with BAK, especially it causes low-grade inflammation, ocular surface disease, which we've been talking about, that causes inflammation in the trabecular meshwork, progressive toxicity, increased resistant outflow. And what happens? We need more drugs because the pressures are getting higher. So we had more treatments, more glaucoma medication, uncontrolled eye pressure before we know it, we're into surgery. So we don't get here overnight. It's a series of steps. But if we can kind of stop this cycle and recognize all this is going on over here, how can I prevent it from getting worse over here by the treatment I'm using? So with that, for the appropriate candidates, how frequently do I recommend SLT as first-line therapy? So that's what I went with for this patient. Regardless of your scope of practice and the state you practice in, how frequently would you recommend that? Knowing what you know now about the vicious cycle in dry eyes and in glaucoma, and knowing that these two conditions are frenemies, they can be almost as inevitably linked, causing dry eye, 50 to 75% of the patient. And then the other one is 0%.
See, Austin, we have some people participating in your poll everywhere, and we have people participating on our side of it. So the results are a little bit different.
Okay. I appreciate those responding in either format there. And my question is for those who may prescribe it half the time or 75% of the time, what hesitation or concerns they would have for that. Now, the patient may not select it. They still might like the idea of topical therapy. But as providers, how can we recommend a proven therapy, especially with the light study, to help decrease intraocular pressure, help protect and delay that blinded disease that Joe was talking about?
So I'm going to display the results on our end. I don't have the fifth choice of zero or the fourth choice of 0. So I only have the 3. And I have 75% to 100 was 28. And then 50 to 75 was 45. And then 25 to 50 was 30. And I don't have your 0 is D. So majority was 50 to 70%, 75% of the time.
And what shows there. And I think this is maybe where it gets to the art of caring for glaucoma. We know the treatment works, but maybe it's how we say it or when we say it. And I think there's still some patients who, because their parents took drops, that's what worked for them. They feel like they want to take drops because it feels like that's a reminder for them they're doing something about it, rather than doing a one-time laser treatment and then doing follow-ups periodically. So it's kind of meeting the patient where they're at. But I think it's still worthwhile as providers to recommend it as first-line therapy if they're an appropriate candidate. Joe, Greg, any thoughts on that?
Well, I agree.
I would
Go
be
ahead,
the
Joe.
one who would be in the lower tier of what was it, 25 to 50%.
Okay.
Yes, I know all about the light study, and we're talking controlled environments with trained observers, specialty technicians. These are well-controlled clinical trials. In reality, I don't think things work as well as purported. You know, I see a lot of failures. There is a limitation. You know, we have an SLT in our practice, but we have to refer everybody has to refer those patients to the glaucoma specialist who does the SLT, because we don't do SLT. We don't have the opportunity to access in Florida. So there's a limitation of access, and I see a lot of patients, they do okay on it, but they don't always thrive on it the way we think. And there are some patients that I'm shocked at how long they have a great pressure reduction from it. But for the most part, I take the pristine results of the light study and recognize in clinical practice, nothing's going to match that.
Yeah. No, that's great. Thanks, Joe. Greg, any thoughts there?
Yeah, I mean, I kind of have the same observation as Joe. I mean, you know, as you know, in the OGS, the Optometric Glaucoma Society meeting, there was a lot of discussion about, you know, the light study and SLT and interventional glaucoma and and really introducing it as kind of a first line therapy. And I have a surgeon that comes in my practice. He comes in once a month, and I can get an SLT maybe snuck on if it's someone that's like first, that's going to be their first line therapy. I'll call them up and ask a favor. Look, I don't want to beat their ocular surface up. Can you sneak them on? Because usually it's 3 or 4 months before he'll see him. So if it's someone that's on glaucoma meds, then I'm not going to call up for a favor. I can wait that 2 to 4 months before they can get in and see him.
Yeah.
But I've sent these, if you want to say virgin eyes, and I didn't really get the same replication like Joe was saying of, it ended up, maybe it was lower. They ended up going on a drop. Maybe the drop was more efficacious after the SLT, or with the SLT going first. So, I'm kind of a 50 to 75% where it's okay, patient, here are the options. You've got drops, you have
Great.
laser, and let them kind of navigate that. But giving them like the toxicities that you showed in that spiral loop, like, we are putting, chemicals on your eye, which does create an issue. But, most of the patients will resort, and I'm not trying to be biased, like, the noise that's out there that you talked about earlier. I try to give them a good, let them pick. And, but I definitely bring it up.
And not, not perfectly benign. Yeah, I've not been to an OGS meeting in a few years because I'm now more practicing neuro-ophthalmology, but I remember being there one year, and you may have been there, Austin, one of our guest speakers, a glaucoma specialist, extolled the his love of SLT and how he would do that all day long. And then about a half an hour later, he detailed a patient with ocular hypertension where he did SLT with a bilateral intractable pressure elevation that required a bilateral trabeculectomy.
Yeah, that's right. It's out there. It's happened. I've seen a keratitis from it before as well.
Oh,
yeah,
yeah.
so I think those are great points. Access issues, efficacy issues, insurance issues. I think it related to access, if it's supposed to be first-line therapy, then hopefully the states will increase our expanded therapeutic privileges for those patients, increase that. Let me show you, that context of the discussion. This is great. I appreciate the perspectives there. There's a really great graph presented just a few weeks ago, a few months ago, called the interventional glaucoma consensus treatment protocol. And I've changed a little bit on this slide, adapted it some, but basically they have the 4 stages of glaucoma: ocular hypertension, glaucoma or mild glaucoma, moderate glaucoma, and severe glaucoma. And the main thing they did is, in order of treatment, they moved maximum tolerated medical therapy to the very last recommended treatment in most stages there. Maybe bridge therapy in these more advanced stages. Recommending laser, procedure to pharmaceuticals, tissue sparing MIGS, with the goal of having tissue preserved for more future treatments down the line if there's progression. The only thing I did to modify this graph, their findings, I added gonioscopy. I feel like as providers, if we do more gonioscopy, we'll have more of an interventional mindset, and we'll be thinking about these different factors and see if they're good candidates. So when I do my gonioscopy, I'll do the qualitative features of what I'm seeing, the most posterior structure, the amount of pigment, any PAS, for example, but also put okay for SLT or recommend future MIGS options that might be good for that patient. So my gonioscopy has a little more detailed information. So when we send the patient for cataract surgery, if that's the case, or standalone procedures, they know kind of what we're looking at. But I'd recommend these 2 things: do more gonioscopy to better assess the angle, and I do more staining. I think as providers, we may have more of an interventional mindset if we did those 2 simple things. We think we'd be better understand the angle and the process. If we did more staining, we'd see the dryness that's probably coming from the topical medications. It doesn't say we can't use the topical medications, but they're suggesting that it's more as a last treatment option. Now, this would be an ideal setting if there's perfect access for the glaucoma specialists and there's insurance coverage and all these things would be possible. This would be ideal setting. And maybe it'll take some time to get to that ideal setting. But I thought it was an interesting graph for you to consider. great reference to read later on at your convenience. If we do have patients with dry eye therapy who have glaucoma and they are on dry eyes, I came up with 5 S's. One is stop or separate therapy. So the question is, do they still need that therapy? Subtraction therapy, maybe we could take away some of the medications and combine them, less BAK preservatives. Switch therapy to maybe a preservative-free medication, or surgical therapy, including lasers. And all along here, do supplemental therapy. So hot compresses, like you mentioned earlier, maybe some nutraceuticals, omegas, doxycycline, azithromycin, whatever you recommend, in-office dry eye therapy. But all these things can help patients who have dry eyes, but also have glaucoma. We can still preserve their vision while minimizing their discomfort. So I guess I haven't gotten to my nerve mnemonic, but this would be the case that'd go with that. And then we're final 10-minute warning. This has been a great discussion. Let me just show this case presentation, and then I can present that later on in closing if we'd like to do that. This is a 75-year-old dry female, again, another elderly female, dry evaluation, but she said very emphatically, my eyes do not feel dry. She said LASIK, cataract surgery, blepharoplasty. This is concerning. She doesn't have any symptoms. She's had LASIK, cataract surgery. And her main symptom is blurred vision and glare. So when I see a dry evaluation with these symptoms and blurred vision, I'm starting to think of more of a neurotrophic component to it and see the reduced vision there. Pressures are normal. Osmolarity was below average. And pretty severe central oval shaped staining, affecting her decreased vision and her symptoms. So we think, well, what's causing it? We see this faint LASIK scar here. That's contributing to it. And they show you a picture of the lids. We see oval shaped staining. It keeps recurring. We did neurotrophic testing. We know some of the etiologies of the different surgeries, and then we acted. And here's what our goal. Here's her lid description. She was partial blinking, partial closure. In fact, I was able to do corneal sensitivity testing in the office, and I checked her eye pressure without any numbing eye drops either. And that's telling for them. When I checked that pressure, I said I didn't have to use any numbing eye drops. They're surprised that they are so dry for so long. So how would you just treat this discussion? Well, one of it was an exposure component. My goal, I thought, let's decrease inflammation, stabilize the tears, restore that neural feedback. And there's it's a multifactorial approach to multifactorial disease. So that's what it showed for the different factors. So for now, what conclusion I recommend is providers, we stain more, doesn't take much, and we do gonioscopy more. These are both 2 tests that don't cost much, but give us high yield in return. More information to help out with identifying neurotrophic keratitis earlier and better caring for our glaucoma with patients. So
Hey, Austin, just a real quick pearl I learned from one of our corneal specialists. When staining, wait, put it. I mean, I'm always rushing. I've learned the value. Put it in, wait 2 minutes, then look.
Perfect. Yeah, that's a great pearl, and that's what I'll do. I'll put it in, and then I'll talk about their history. Tell me more. I'll ask them 2 questions, and it takes about 2 minutes. What's your main symptom, and when does it bother you the most? And maybe we'll elaborate on those answers. After those 2 questions, it's about 2 minutes, then I'll take a look at the staining. Thanks, Joe, for bringing that up. That's an important factor there. If we don't stain, we just don't appreciate it.
Let me go one step further. If you're using Rose Bengal or lissamine green, it's even longer. Because this is a water-soluble stain, so it still takes time to dissolve and get it to that 2 minutes, but 3 or 4 or 5 minutes to be able to stain that cell membrane of that devitalized cell, because those are fat-soluble staining cell membranes when you're using lissamine green or Rose Bengal.
Yeah, great point. What a simple procedure. It doesn't cost much, but it gives us so much information. Again, it's not normal. We should be concerned about any staining, so that's perfect. So I didn't go over the nerve mnemonic, but let me just kind of go over it in general here. In closing, then we'll do the dry eye one. So for NERV, the idea is to diagnose glaucoma earlier, and it doesn't rely on pressures or CD ratio. Basically, the N stands for nerve. What's the overall nerve appearance? Is it a small nerve or a large nerve? Is it inserted, tilted insertion, suggestive like myopia? What's the overall retina look like? E stands for the extent of rim loss. So this black one up here, I'm looking at the rim. How much rim loss is there? Where's it located? The hot spot for glaucoma is inferior temporal and superior temporal. So look at the vertical meridian and 15 degrees temporal. That's where you're likely to see glaucoma damage. So that's for the location. Look for the amount. While you're there, look for pallor. That would suggest any non-glaucomatous optic neuropathies. Another one that I'm looking for lately is crescent moon sign, meaning does the cup, is there discontinuity between the superior rim and inferior rim? Does it form a crescent moon shape to the rim there? R is any retinal nerve fiber defects, either local or diffuse. V is all things vascular. So looking at the central retinal vessel trunk, the location determines susceptibility. So if the location is central, more stable nerves. If it's decentered, superior, then inferior might be more vulnerable. There's not that vascular or structural support. So I'd be concerned about the inferior area if that's the case. Look for any vessel attenuation like an old BRAO, any collaterals like an old C.O.R.N.E.A. Look for any disc hemorrhages and a location for you. And looking for
Austin,
basal.
when you have time, can you go over the crescent moon sign again? But you can finish out your
Yes.
E here.
Yep.
So
I will. That's a good one to do. And then S is anything, if there's anything suspicious on the nerve, do some other testing. In other words, the nerve should be symmetrical, the test should sync. But if nothing looks, if it doesn't look right, then do some additional testing. So let's see if I can pull this out and go over the crescent moon sign. If I just push escape, that'll get me back to my nerves, right? Okay. Let me go back up here, Greg, just a second.
yeah, go ahead. You're not sharing anything now, but I think you know that.
I appreciate the question because that's an important part of this crescent moon sign. It's something that I thought, let's see here, was new data, but it had been out for several years. Okay, I'm going to pull up here again. So we talked about the E is extent of rim loss. And we look at the location, look at the vertical meridian, and look 15 degrees temporal. And that's where the hotspots are. If glaucoma is a thief of sight, it always goes back to the same scene of the crime. So look here and look there. The other one is this crescent moon sign. So among myopic patients, is there discontinuity between the superior temporal rim and the inferior temporal rim? If so, that's suggestive of glaucoma among myopic patients. It's hard for me to determine if a patient who has myopia has glaucoma, but the crescent moon sign is a good pertinent negative. Compared to here, you see how this superior rim is continuous with the inferior rim? That means there's, we don't have that crescent moon shape, but here it's this crescent moon is what we're making for the sign there. And it's most commonly inferior temporal. If there's discontinuity between this rim, it provides an important diagnostic indication of glaucoma among myopic patients. And then we look at rim pallor. Usually it's inferior temporal more than superior temporal, but I'm looking at that now, and that's a good way to pick up any early glaucoma damage. And if there's any rim pallor, as we mentioned, extend outward, it's a sign of non-glaucomatous optic nerve damage. I'm gonna jump back to where we were there. Does that help kind of answer your question?
It did. Yep.
Yep. I thought it was new data, and then it turns out it was 2014 they had it in there.
And that's mainly for myopic discs.
Only among myopic patients.
Okay,
Yep.
perfect.
Yep. So it's hard to pick that up. We talked about the cornea, just to review. And then in closing, how we can do it is look at the eyelid closure. So how to assess glaucoma patients and dry evaluation at the same time. Look at eyelid closure, look for coronal sensitivity, look at the lashes, look at the eyelids, look at the tear quality and quantity, tear breakup time, look at the coronal surface, and check the staining pattern. This is an opportunity to assess these dual dilemmas. And the goal is to download all the data. Put the pieces together, whether it be dry eyes or glaucoma, balance the treatment versus the clinical signs, come with a mutualistic approach the patient and the provider agree upon, and push start. And then as providers, repeat. Every time we see them, we're looking for glaucoma and dry eyes. Two parallel diseases, if we can treat them earlier, we have stage stabilization, prevents that progression. And there's a great book called The Power of Positive Deviance, Better Providers, Better Care. In summary, they're saying that in every situation, despite people have the same resources, some providers do some things differently. They use different resources. For this lecture, I think if we just do things differently, use staining better and gonioscopy better, we're a positive deviance in a setting like that. So hopefully by doing those mnemonics of have a systematic evaluation of the nerve, systematic evaluation of the cornea, we can prevent, that's my alarm there, sorry. We can prevent further progression. We can ensure stage stabilization of these two parallel diseases. Thank you, Joe, and thank you, Greg, for letting me join in tonight. There's some questions there. You can feel free to email me as well, but I appreciate the discussion. I know we didn't get to all of it as much as I hoped for, but this has been fun to be able to talk about and answer some questions, so thank you.
Well, Austin, as I always say, the Rolling Stones don't play every song they know at every concert, so there's no
Okay.
worry. It's always better to leave them wanting more than to overstay one's welcome.
Yeah, thank you, Joe.
So you had some QR codes up there. What were the QR codes for?
One was a website I had there, and then this is my Instagram account. I believe this one right here. So it's glaucoma QD. It's pretty nerdy. If you want to follow for some more cases on glaucoma, you can click on that. The idea is think about glaucoma every day, every patient.
And the website has what information?
It has some articles, key articles from key for different topics. I guess I should have changed that a little bit more for you, but more additional resources. It's things I actually learned that during my glaucoma diplomatic process, Joe. Things I picked up and thought was helpful for me.
Fantastic. And so there's the QR codes if you want to scan them, but they're also in the handout, I believe. So they can always download the handout and scan them from there. Perfect. So Joe, are there any questions that have rolled into the chat?
No, we have been very good at keeping up with those. So we were good.
So with that being said, if everyone looks at their platform that we're using, the C.O.R.N.E.A platform, you'll see this little red dot right there. You can start doing that survey. We need that survey for, again, closing those gap closures so we can continue to offer these courses. So please do that for us. I already asked Joe, so there are no further questions. So thank you for go ahead, Joe.
He is getting Austin, just getting your virtual round of applause from the audience. So everybody's thanking you.
Thanks again, everyone, for joining tonight. I really appreciate it.
I think I can hear it. I think I can hear the claps right now. So with that said, questions have been answered. Thank you for doing cornea and nerve, two novel mnemonics to preserve vision in two parallel diseases. I think you highlighted that beautifully, you know, the strategy behind everything. We can't separate out. We always talk about these different pillars and we start doing it ourselves and, you know, looking at the eye as a whole, looking at the body as a whole. So you did a great job pulling that all together. So thank you for being a part of this of Optometric Education Consultants National Webinar Series. Thank you very much.
Thank you.